Welcome to The Code Tray, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter is going to be Tom Szwajnos, a PGY2 emergency medicine resident at Advocate Christ Medical Center, who will be presenting on magnesium in addition to prochlorperazine in the treatment of migraines, the MIGraine-2.
I do want to start off with special acknowledgments to the ED pharmacy team here at Advocate Christ. Without them, this project would not be possible and we would not have the enrollment that we have today. And to get into a little bit of the burden of migraines, so it is the second worldwide leading global disability, with a very costly one at that, at about $27 billion per year in economic burden. But the number I really wanted to highlight is there's probably over 3 million ED visits per year. So regardless of the emergency department that you work in, these are patients that are likely going to be coming across your doorstep that are going to need some type of migraine treatment at some point in your career. And so when we look at the mechanism of migraine, there's a few different ways that migraines start. So the initial phase is this wave of cortical depolarization, where these electrical signals trying to travel through the brain and activate the migraine or the brain into a migraine state. Sometimes it will travel through visual cortexes, which will be responsible for causing that aura that patients often present with. Next, the trigeminal vascular system is going to get activated, and this is where the pain signals are going to start, and the patient's going to start feeling that initial pain of the migraine. Then we'll see neurogenic inflammation take into effect. That's going to further increase the pain response and further make the migraine have more potent symptoms as well. And when I think of serotonin dysregulation, I think of that as like the volume control knob for the migraine. So kind of regulating the intensity of the migraine, but then also contributing to things such as nausea and vomiting. And so when we look at the trigeminal vascular system, there's a few different components that go into it. Where we see CGRP, or calcitonin gene-related peptide, that's going to increase neurogenic inflammation. Our substance P is going to be our pain signal amplifier, and our neurokinase is going to be another inflammatory mediator that all kind of lead to this pain sensitization as well as vasodilation, which further amplifies the pain response in migraine as well. And so when we look at our migraine treatment toolbox from guideline-directed therapy, first-line agents are going to typically be dopamine antagonists, often in adjunct with things such as diphenhydramine. Other options are going to be your analgesics, which are going to be your opioids, your acetaminophen, NSAIDs, et cetera, as well as some of these other agents such as triptans and CGRP antagonists. But what you'll see here is that the guidelines don't really take a clear stance on where magnesium fits into the treatment of migraine. But when we look at the role of magnesium, we see that it has we see that it has very different mechanisms to also mediate that migraine response, starting with the neuronal membrane stabilization, which kind of helps mitigate that initial migraine response. Then we see vascular tone regulation, where it will help mediate the initial inflammation, that inflammatory response. We'll see decreased pain with NMDA receptor inhibition. And then going back to the serotonin receptor modulation, it's going to help regulate some of the intensity of that migraine, as well as help to limit some of that nausea and vomiting as well. And when we look into the literature, magnesium actually has a pretty robust history in the literature as well, starting in the 1990s with Moskop and colleagues. They looked at magnesium 1 gram both in cluster headaches and generalized headaches. And they wanted to see if there was a correlation between serum magnesium and headache migraine relief. And they did find that patients who had lower serum magnesium tended to have better pain responses when given magnesium. And in their studies, they saw that those who received magnesium had about 80% of pain relief, which was very impressive. Then in 2001, Kroll and colleagues looked at magnesium plus metoclopramide versus metoclopramide alone. And they wanted to look at difference in pain scores using this visual analog scale, as well as things such as adverse events, recurrence of migraine symptoms, and return to functional status. And interestingly enough, this was one of the few studies that actually had less of a benefit when combining magnesium with another agent, where the metoclopramide group actually did better by itself. Their rationale or their theory was that magnesium can provide a vasodilatory effect, and that vasodilatory effect was potentially canceling out things like metoclopramide in this trial. Then in 2005, Seat and colleagues compared magnesium versus metoclopramide versus placebo. And they also wanted to look at pain scores using that visual analog scale, as well as need for rescue medications and 24-hour recurrence rates. What they found is there really was no change in VAS scores between groups, and that the 24-hour recurrence rates were not statistically significant. But what they did find was that there was actually a higher trend towards rescue medication requirements in the placebo group, whereas the metoclopramide and magnesium groups had lower rescue medication use and was comparable to each other. indicating that potentially magnesium does have a benefit in decreasing the amount of rescue medications required. And lastly, the final study that I wanted to talk about was by Candle and colleagues in 2020, which was magnesium versus metoclopramide versus prochlorperazine. They also wanted to look at pain scores at 30 minutes, but also at the 45 and 60-minute time points, as well as need for rescue analgesia and ED length of stay. For rescue analgesia and ED length of stay, they found no difference. But the graph that I wanted to point out here was that when they looked at the pain scores from each time point at the 30, 60, and 120-minute mark, they found that there was no statistical difference between the pain scores for any of these groups, meaning that magnesium, metoclopramide, and prochlorperazine were all non-inferior to each other, meaning that magnesium performed just as well as the guideline recommended first-line therapy. And so that brings us into our study where we've seen trials that looked at magnesium use alone, magnesium compared to other agents, and even magnesium in combination with some of these other agents as well. But we found that there was no literature supporting the use of or showing the use of magnesium in addition to prochlorperazine for the treatment of migraines, which is why the purpose of our trial was to compare the efficacy of prochlorperazine versus magnesium plus prochlorperazine combined therapy for the treatment of migraines. We accomplished this by doing a prospective double-blinded randomized controlled trial at a single center here at Advocate Christ Medical Center in Oak Lawn. We started enrollment November 1st of 2025, and the interim analysis for this presentation goes up to May 26th of 2026 of this year. For our inclusion criteria, we included patients who had very specific migraine characteristics and migraine symptoms, specifically relating to unilateral location, pulsating quality, recurrent in nature, having that nausea and vomiting, as well as photophobia and phonophobia, while also having a clinical exclusion of migraine mimics. We excluded patients who were pregnant, anyone who had any study drug use within the past 48 hours of enrollment, and then any contraindications or allergies to any of the study medications as well. For our statistical analysis, we used descriptive statistics, as well as chi-squared or Fisher's exact test for our nominal variables. We used one-way ANOVAs or non-parametric Puskal-Wallis test for our continuous variables, and we needed a total of 100 patients to detect a 15% reduction in pain scores with a 5% estimated dropout rate. For our primary endpoint, it was the mean change in pain scores from baseline at 30 minutes post-infusion using this numerical rating scale between 0 and 10, with 0 being no pain at all and 10 being the worst pain imaginable. Our secondary endpoints also use that numerical rating scale to look at pain scores, but at the 45 and 60-minute time points. And we also looked at need for rescue medications. We looked at adverse effects specifically relating to things such as flushing, headache, nausea, lightheadedness, and akathisias. So for our intervention, patients were either put into the placebo group or the magnesium group. Regardless of the group they were in, these medications were put into a 50 ml normal saline bag and infused over 20 minutes. And then all patients received prochlorperazine 10 milligrams as an IV push, plus diphenhydramine 25 milligrams as an IV push. At the time of this interim analysis, we had enrolled 64 patients. One patient was excluded because after enrollment, the provider deemed that the etiology of the head pain that they're experiencing was likely not migraine, and therefore we did not provide them any of these study drugs. That left us with a total of 33 patients in the magnesium group and 30 patients in the placebo group. And for baseline characteristics, we see that the average age of these patients was around 30 to 40 years of age, with the majority of patients being female, with a slight trend towards a higher percentage of females in the magnesium group. About a third of patients experienced an aura, and about half of the patients had a type of migraine history with a slightly higher trend towards the magnesium group. Baseline pain scores were similar, and prior to enrollment medications occurred in about half the patients as well, again with a slightly higher trend towards the magnesium group as well. And we found for our primary and secondary results in regard to pain scores, we found that the most significant reduction was at the 30-minute time point, where we did see statistical significance. When we got to the 45 and 60-minute time point, the pain scores were lower in the magnesium, but were not statistically significant. So what we found from this is that the magnesium in combination with prochlorperazine seemed to result in a more rapid pain response or a more rapid reduction in pain, with nearly double the decrease in pain compared to the placebo group here. And when we looked at rescue medication use, we actually found that that was pretty identical between both groups and not statistically significant. But when we broke it down, we saw that NSAIDs were the most commonly prescribed rescue medications, along with other agents such as acetaminophen. And for adverse events, we did see a slightly higher trend of adverse events in the magnesium group, but we also saw that this was not statistically significant. The other two things that I wanted to point out with this slide was that there was a higher amount of flushing in the magnesium group, which makes sense as it does cause a vasodilatory effect. So it was not surprising to see a higher rate of flushing compared to no flushing in the placebo group. What we did find that was interesting, though, is that the magnesium group did have a higher rate of drowsiness, despite both groups receiving diphenhydramine. Our postulated theory here is that these migraine patients often enter a post-stromal phase that often results in lethargy and drowsiness. And so since magnesium gave a more rapid response in pain reduction, that potentially these patients are entering the post-stromal phase or having a more significant response to that post-stromal phase than the placebo group. And as far as our limitations, unfortunately, we're not able to control for any prior to enrollment medications. So many of these migraine patients often have prescription medications that they take, or they'll often take over-the-counter medications, but unfortunately unable to control for that as they come to the emergency department. The NRS scoring that we use is relatively subjective in nature, so that can vary from patient to patient, even time point to time point. So at times we'll see that patients would want to know what their previous score was, and sometimes would even try to change what their most recent score was, depending on what they had said previously. So again, relatively subjective in nature. This was a single center trial and relatively small sample size based on this interim analysis, but we still have full enrollment needed to be completed still at this point. So in conclusion, from our interim analysis, we're seeing that magnesium in combination with prochlorperazine is resulting in overall greater pain reduction and better pain scores than just using prochlorperazine monotherapy alone. We did notice that magnesium had a higher rate of adverse events, but primarily consisted of flushing and drowsiness, so overall relatively transient in nature, and did not outcompete the benefit of using magnesium for the treatment of migraine for these patients. That being said, we were at about 66% enrollment here, so full enrollment is still needed to determine the overall role that combination therapy has and kind of where magnesium fits in migraine treatment. That is all the time that I have. These are my references, and I'll be happy to take any questions that you all have for me. Thanks so much for having me here today.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.